Afternoon, everyone. My name's Kelly Bruce. I'd like to start with an acknowledgement of country, and we're zooming in today from Nipaluna, Hobart, at the foot of Kanani, our beautiful mountain. Please feel free to let us know in the chat where you're zooming in from today, where you're joining us from. I pay my respects to the traditional and original owners of this land, the Muwawina people, who were the original custodians and who didn't survive colonisation of this land. I also want to acknowledge today's Aboriginal people who are the custodians of this land, and we want to acknowledge their knowledge, stories and strength of the Palawa people and celebrate their enduring connection to land, sea, sky of this incredible island of Lutruwita. So thank you for joining us. I'm the new CEO of Women's Health Tasmania, and I'm really proud to have joined the team here and be able to build on some of the amazing work of our previous CEO, Jo Flanagan. And one of those incredible building blocks that she established was the Tasmanian Reproductive Health Conference that we held earlier this year, and some of you may have been lucky enough to join us with that. And I'd like to introduce and welcome Dr Gemma Dwyer, who actually spoke at that conference. And today she's delivering a modified version of that talk, Innovating in Regional GP Practice, a case study in providing reproductive health services. So Gemma's a local Tasmanian GP. She's previously worked at family planning in Hobart and currently works at the Derwent Valley Medical Centre in New Norfolk. And in her work in New Norfolk, she's introduced IUD insertions, early medical abortion with ultrasound, pessary insertions and youth-targeted outreach clinics to the region. And she joins us today to share that experience. But before we get started, a few housekeeping notes. You may have noticed this webinar is being recorded so that we can share it on our website for those who can't attend today, but all the participants today will be sent an email next week with the link to this recording as well. There'll be time for Q&A at the end of Gemma's presentation, so please include your questions in the chat. Our team will be monitoring the chat throughout, and they may be able to answer some of your questions as we go, but we'll save some of your questions for the Q&A at the end with Gemma. So welcome, Gemma. Thanks for taking the time to join us today and to share your experience with us.
Thanks so much, Kelly. I'm really excited about today. And again, thanks everyone for tuning in. Oh, sorry, my video stopped. Turn it back on. And also in the future, for those who are watching the recorded version, I'll just share my slides. Here we go. Perfect. Again, so yeah, thanks for tuning in. I'm a GP who works in Norfolk, for those who haven't met me. Today, I'm going to be talking again about us introducing, offering medical terminations of pregnancy in Norfolk, but also a few of the other services that we offer that we haven't offered ever before. So we really kind of ramped up the services in the last few years. A little bit as well, half the talk will be about terminations and some of the challenges we faced, and then the second half will be about some of those extra services we've started to do. For a bit of background, for those tuning in not from Tassie or who aren't Tassie locals, you might not know where New Norfolk is. We are slightly northwest of Hobart, about 35-minute drive from Hobart. Our clinic, Derwent Valley Medical Centre, is the only clinic for the whole region, which is the Derwent Valley, which is on that map, the black outlined area. And New Norfolk is kind of the circular red area there. Has a population of about 11,500 people. It's generally been quite a disadvantaged community as well, with classifications for how we rate advantage and disadvantage in Australia. New Norfolk is in the 6th lowest percentile for advantaged communities, which means 94% of Australian suburbs are more advantaged than New Norfolk. As well as that, even just compared to the rest of Tasmania, on average, people living in Norfolk have a significantly lower median household income. A median weekly income per person in Norfolk is about $590 versus $700 for the rest of Tasmania. So again, in general, quite a disadvantaged community. It's also historically had really high rates of teenage pregnancy. It's hard to know now what the exact rates are. The ABS doesn't report that data anymore. But back in the early 2010s, we had such high rates of teenage pregnancy that family planning had special state funding to provide education to the area. So just a bit of context for how important it is to be able to offer these services to this community. And that's a beautiful photo looking up the river towards New Norfolk in the city centre there. And again, a bit about us. So as I said, we're the only clinic in the whole of the Derwent Valley area. We're likely to be locally owned by 2 of the GPs who work there. In the photo, you can see there, the doctors are in the blue tone scrubs and Lester is on the right. He's one of the owners, and I think Gonzalo is tuning at the moment, who's the other owner. We have 13 doctors at the moment employed, but it's about 7 full-time equivalent. When I started in 2021, we had no one prescribing medical terminations of pregnancy, no one offering intrauterine device insertions. So we're lucky to have come a long way. And the nurses, the ones in the maroon scrubs, are 3 of our nurses who support all of these services, but especially our termination services. So to get started, as I said, about half of the talk will be about our terminations of pregnancy and all the logistics around this, as well as the challenges that we face setting it up. But as I said, feel free if you have more detailed questions to put them in the chat, or you feel free to email me later. As far as starting off, I think it's fantastic to utilise some of the training opportunities, and there's really fantastic resources available for Australian doctors and healthcare workers who are interested in being involved in terminations of pregnancy. It's no longer mandatory for doctors to do the MS 2-step training, but it's still free online, and I think it's a really good starting point to get your head around in depth all of the risks you have to be aware of, all the kind of rare things that might happen when prescribing MS 2-step, as well as it has fantastic resources available to keep using in your practice. I've also learned a significant amount from online communities, and there's a few really fantastic Australian resources. 100% I would recommend nurses, doctors, clinical staff signing up to the AusCaps network. There'll be a QR code at the end with some of their details, but that's a free education platform that not only has resources, but has really fantastic just posts about clinical situations that you might not have come across before. It really helps cement a bit of understanding but confidence in prescribing for early medical abortions. There's also a Facebook group that's kind of an offshoot of GPs Down Under called MTOP Docs Down Under, and similarly there's a lot to search through there for cases. Luckily in Tasmania, we're quite a small community, so there's also a lot of support from local doctors. If you have any questions, Family Planning Tasmania is fantastic, and I'm sure if you have any questions you could either refer there or even just give one of the doctors a call. We'll go into detail a bit later about offering ultrasound in your clinic, but there's some really fantastic ultrasound courses, and there's an organisation in Melbourne called CEDU, which has a specific MTOP ultrasound course. But also there's so many online learning modules, and especially for our nursing staff, I think that really helped establish some of our process and their understanding. They're often posted on AusCaps, these opportunities, but there's a few through Sexual Health Victoria and some of the nursing organisations as well. And so obviously everyone's often coming from this with different experiences. It's great, I think, if you feel like there's gaps in your knowledge, to look into some of these. A lot of the nursing modules are also free or fairly low cost as well. The way we set up our appointment structure has been a very slow process as we've figured things out. We've modelled it a lot off of the family planning model, but I think, again, every clinic will run really differently because everyone has really different availability of the nursing staff, of appointments just in general. But we found this works really well for us and making it quite seamless for us and the patients. So we introduced a nurse triage phone call, which again is similar to family planning. We were lucky enough to help facilitate some of our nurse learning as we were involved in the Orient trial, which was an Australian trial to help introduce nurse-led LARCs and early medical abortion in regional general practice, which did help fund some of the education and time for our nurses to be involved in this. It helped us create an autofill just for our nurses to be able to provide information to patients. Before we had all of this, when we first started offering terminations, it was very common for patients to call, very stressed, in distress, not sure what to do. And obviously reception staff who aren't clinical are sometimes trying to find out more information, but they're obviously not trained in taking history. It often just led to a lot of more distress for reception staff, a lot of running around trying to find a doctor who's happy to squeeze them in. Whereas sometimes it's not urgent to get in for a medical termination. Sometimes they're too early and do need to wait for an ultrasound. And so trying to find that perfect timing is kind of a clinical decision, and we found our nurses a much better place to do that. Our system is that when a patient calls the front desk and mention they're interested in termination, our reception will just book it in with the next 24 hours of one of our nurses, and they'll get a chance when they have time to call back the patient and again go through our autofill that includes some information about what terminations are, because again they might not need a really long appointment to organise the medication if they want a surgical option. They might want a shorter appointment sooner just to talk about it. They need to be aware of the cost and the appointment follow-up with us. And so that's kind of the perfect opportunity to do that before the actual appointment. Then again, it depends on your clinic structure, and I think lots of clinics do this differently, but we offer 2 or 3 appointments depending on if we do the ultrasound and prescribing appointment all in one. Currently, I'm the only doctor at our clinic who does that, so the other doctors would do 3 appointments, and I offer 2 appointments. The first appointment would normally be the history, counselling the patient on the options and what's involved, and organising blood test and ultrasound. We at our clinic don't offer very early medical abortion, and I'm actually not sure of anybody in Tassie who does, which is where you skip the ultrasound. So there's people who are still ultrasounding to make sure that the pregnancy is intrauterine and you can go ahead. And then for me, who can do the ultrasound in that same appointment, I would also then do the consent and prescribing, but for some of the other doctors that organise an ultrasound elsewhere, and then get them back for the prescribing appointment. Back when I did an ultrasound, I would normally, because often it's time sensitive, personally book the ultrasound with the patient there, make sure they're able to go to it, and book the follow-up just so we had some definitive timeline, so that again it was less stressful patient and we knew when we could book the follow-up, especially when you can be booked out for a while. It can be stressful for patients to figure that out. And then the third appointment is the follow-up, which is normally 2 weeks later, which most places would do. We again are lucky, being part of that previous trial, that our prescribing appointment would normally include half an hour afterwards with the nurse, and we've set up again a separate autofill. Part of this is to save time for the doctors, so the nurses will be able to answer extra questions, but also they'll book the follow-up appointment, they'll put the reminders in the clinical software, they'll make sure things like the patients know where to buy the medication from. I think not only is it useful because it means that what can be a really long consult for the doctor can be a little bit shorter, but it gives the patient a chance to kind of take a breath, think about what they've been told. It's often a lot of information, and then be able to ask more questions before they actually leave the clinic. Second positive that I found as well is that a few times we'd have patients who couldn't get in elsewhere and would be calling around. They'd drive out to Norfolk and see myself, and often they're not keen for follow-up. Really often they would not have any baseline bloods done, even when they're given the form and said to do it on the way out. And so it's an opportunity to kind of make them do the blood test before they actually leave the clinic space, which has worked well for us. In regards to costs for offering terminations, as far as setting up, if you don't have an ultrasound, it's really just the costs of the training, which, as I said, MS2 step training is free. So there's really minimal cost to set it up. Sometimes there's logistics for deciding how much you're going to charge patients. Do you have paperwork for that? But that's all very straightforward. Luckily, we'll come back around, but we'll talk in a minute about setting up an ultrasound machine though, because that's, I think, we're quite lucky to have an ultrasound machine. It's a very new thing, and maybe it will be the future of primary care, but it is still a major cost in our service of offering terminations. The cost for the patient, we make sure it's really clear on our website, and I'm aware that most places in Tasmania will charge a gap, even if it's a reduced gap like family planning can charge. And most providers in Tasmania, it's pretty easy to see on the website, so patients can access that beforehand, luckily. We also make sure the nurses discuss it in advance. That really helps us set up if they do need to access external funding. And we've decided as well to kind of load some of the cost of the actual appointment time, rather than just charging a time-based consult. We charge a little bit more because we bulk bill the follow-up. We just charge that to Medicare, as we found that it's common that patients don't turn up to that. It's a bit of incentive for them to definitely come back. And also, if they don't turn up, if I don't charge do not attend fee again, that's kind of all involved in the initial cost, knowing that there's really high rates of people not coming back. As I mentioned, there is external funding, and Tasmania is really lucky that the state government funds the Women's Health Fund and the Youth Health Fund that can help pay the out-of-pocket costs for terminations for patients. I've got a little bit more information about that here, and some of you may be aware of it, some not. So I'll go into a bit of detail. The Women's Health Fund is organised by Women's Health Tasmania, and that's for over 25 people over 25 years of age. I find it's really convenient. We have the application form in our clinical software. So the way I normally do it is just fill it out myself on the day, and we just send the invoice off. It is for patients who can't afford it. So, ideally they have a concession card or some reason why they wouldn't be able to afford it. I generally just offer it to patients who I suspect it will be an issue, especially if they do have a concession card. And you'll find some people are happy to not go with external funding, and some people do need it. The Women's Health Fund is just there to fund long-acting reversible contraception and terminations of pregnancy. And that includes, the actual visits, the prescribing appointment, but can involve the medication if needed as well. So if you do need more information about that, I think it'd be good to reach out to Women's Health Tas just to clarify the way that you might go about it. I find personally for most patients, if they're buying the medication, they have a concession card, it's on the PBS if they have Medicare. So it is only $7. It is often easier, they'll pay that small fee, but the fund will pay for the consult. You don't have to fill it out on the same day. The application can be done in advance, but I find it's really convenient just to do it on the day. You don't have to get prior approval. This is different to the Youth Health Fund, which is for under 25 years of age. This must be approved prior to the service, which helps facilitate when we have that nurse triage call, that it's just sorted out before the actual visit. There can be exceptions for terminations, and you can try and call on the day, but sometimes it is a little bit more challenging, especially if you can't get a hold of the link. It is a little bit more expansive, this fund. It not only covers LARCs, terminations of pregnancy, but they can provide other funding for healthcare in settings of severe financial hardship. So occasionally we'll use it for things like mental health care plans, which the Women's Health Fund can't cover. As I said, it has to be done in advance, and it has to be approved through a youth access worker. And normally those, they work for the link. Occasionally people will work as social workers in other environments, but mostly I'd advise patients to call through to the link, and I write down the link's number, and they would organise it beforehand. Normally the link as well would send us that information before the appointment, so we already know that it's organised, and then once the service is done, we just send off the invoice to the link. We are lucky, and I'll mention it again a bit later, some of the challenges, but we did have a few issues personally in New Norfolk accessing the Youth Health Fund, in that sometimes people did really struggle to call through to the link, even if it was just because it rung out or they felt scared of calling through to the link. Sometimes as well, patients do have to travel into to Pulse or the link to physically sign the paperwork, and that was difficult for patients from Norfolk. So we advocated, and we're lucky to have our nursing staff be youth access workers as well. These are much more convenient to do it in-house. In saying that, that was an exception, and there's not many clinics in Tasmania who can do it, and I think partly it's being more regional that works for us. For most people, if you're in Central Hobart, it would be pretty straightforward to get patients just to rock up to the link on Liverpool Street or to call them. And then next, talking about equipment, as I said, for terminations, actually there's not much you need. I use patient booklets and handouts and consent forms that are just already done by MS Health. If you do the MS two-step training, you'll have a login, and they'll just send the resources out for free. So I find them really valuable, and I just recommend using those ones. There are other consent forms that other clinics use, but the MS Health ones are really easy to use. My other recommendation for equipment would just be to have autofills in your software. There's a lot of information to cover in the visits, and it can be easy when you're distracted trying to write things and look back at the patient to forget what you've counselled them on, what risk you've mentioned. There's just so much to go through that I find autofills for each of the visits just means you don't forget things, and it kind of prompts you to make sure you've documented information you've covered, especially if I had to follow up with somebody else, say you're away, it's very clear what day they would definitely take the medication, what day you expect them to do follow-up blood tests. A big cost as well for us is the ultrasound machine, which we'll discuss on the next slide. And then lastly, you might have equipment for organising follow-up contraception. And we'll come back to that later as well. But things like being able to offer IUDs, implanon can involve equipment available as well. Now talking about ultrasound machines, some people might just skip over this, but I thought I'd mention a bit of detail because it can be a bit confusing. There's, as I said, there's not, as far as ultrasound in general practice, there's such a breadth of what you can do that there are a lot of different courses. I really recommend, if you're going to do termination of pregnancy, that ZDO course in Melbourne is fantastic. It is about $2,500 just the training, and they offer blended training. So you do all the learning online, and then you have one day in Melbourne where you get to practice on actual volunteers, which is very invaluable. I think especially if you're doing internal ultrasounds, being able to practice like that on people who are consented, who are happy to, gives really important experience to being able to offer ultrasound. There are lots of other ultrasound training courses available though, and again, mostly from ZDO, but there's another organisation in Queensland who does really thorough ultrasound training for those interested. But again, it's such an expensive thing to be involved in still. I think it's becoming the future of being able to offer bedside ultrasound. But who knows what will happen over the next 5 to 10 years. In regards to which machine as well, I think I don't have fantastic advice on that. It is really dependent on where you live and work. In Tasmania, I'm aware that a lot of clinics have had issues with not just getting the machine, that's normally straightforward, but having the machine regularly serviced. Lots of places don't actually service the machines in Tasmania, which is a huge factor to take into account if you're interested in a machine. There's lots of brands. Our clinic has the Sonoscape E2, but I think they might be difficult to purchase now in Tasmania. There's also, I've used the GE Visana, which is what they have had at family planning. You can get Philips handheld ones now, some that just connect to your phone, or some have tablets. The negative of the Philips ones is there's only transabdominal or linear probes, and so you can't do an internal ultrasound. I think if you're going to offer a termination service where you plan to definitely do it all in one, it probably is very important to think about having an internal probe available, just because of the risk that some people's uteruses are very retroverted. It can be really hard to see the uterus, even if they are close to the final gestation that you need. And so it'd be kind of risky if, they were 8.5 weeks and you thought, it's probably too early, we'll just organise a formal ultrasound. But by the time they came back actually on it, it's too late now, they're past 10 weeks, and it's just the position of their uterus that you probably could have prescribed the other day. But again, there's such a cost to that. And so in regards to cost, most machines would cost between $40,000 to $60,000. Again, even if you were to manage to advocate and get funding through organisations like, Primary Health Network TAS, even then often they wouldn't cover like the full cost of something like that. Maybe normally they'd match 50-50 if you could justify it. And so, it's a huge cost for a clinic. Not only is the cost of the machine, and that's talking about the laptop style ones that are on the big plastic stands, but also you have to have the probes that will go with it. And so you normally get a curved probe for doing transabdominal scans, and a linear one, a flat one, for things like deep implanon, stuff like that, musculoskeletal things. They're probably $5,000 each as well. And then our transvaginal probe, I think, was close to $10,000 when you added on the GST. So you're looking at easily $80,000 to $90,000. You could do more for an ultrasound machine with all the probes. For a transvaginal probe, you also have to be able to sterilise it, and most people use a Tristel wipe system, which is quite expensive. It's about $8 per set of wipes just to sterilise the probe. I personally bulk bill the cost of the ultrasound, but it is kind of included in the full cost of the appointment, because it is just, again, such a cost for the clinic. And top of that, clinics can organise getting Medicare rebates for doing what's called non-referred or NR ultrasounds. So I can bill, at our clinic, we can bill Medicare for doing ultrasounds. To be eligible for that, you also have to get what's called a location-specific provider number, or LSPN, for the machine itself. So that's attached to the machine. There's a lot of paperwork to do for that. And again, most clinics, my understanding, is pay a service who will do all that paperwork for you. That, again, is easily another kind of $3,000 or $4,000 off the top of my head. Again, luckily, clinic owner organised all this, but around that is my understanding. That's what helps open up the Medicare rebate. It does mean you definitely as well have to service the ultrasound machine every 3 years, and that can also cost, you know, $5,000. Our machine had to be sent off last year to Perth. It was the only place we could have it serviced, and so that meant a week of an ultrasound machine, and again the cost of the freight and all of that. The Medicare rebate as well for, you know, a pregnancy ultrasound earlier than 12 weeks is only about $38. So it's not a lot of money. And after 5 years, that drops to 50% the rebate. And after 10 years, you don't actually get a Medicare rebate. So again, these are huge costs to be able to offer ultrasound for terminations of pregnancy. In our regional clinic, again, we do it, like a lot of our doctors luckily use it for other reasons. I think again, it's becoming more common to use in general practice for things like, you know, maybe mild fractures that you might want to rule out immediately, musculoskeletal reasons, checking for deep vein thromboses, doing other obstetric ultrasounds, or checking for IUDs. Like there's lots of other reasons you might use it. But I think it also may be hard to justify unless you're doing a lot of terminations to pay that cost for an ultrasound machine. Sorry, just make sure it's all sharing all right. And again, if you have questions, we might chat about at the end. Lastly, talking about terminations, just a few of the challenges we faced. A really key one for us is just patients being aware that we offer it. For a long time, it hasn't been offered in the clinic. The clinic's been there for decades and decades. We've only offered it since 2021. And before this as well, there hadn't really been long-standing female GPs at the clinic. So even then, a lot of female patients wouldn't come to us and would go to family planning. It's taken a long time to slowly kind of build up a bit of knowledge. And even now, most of our terminations are referred from family planning because I used to work there, and the reception know where we are and that we can fit people in. I'll quickly go to the next slide, but another useful place that's, I'm not sure if any patients have been sent away from this yet, but is a fantastic website run by Women's Health Tasmania, is the Pregnancy Choices Tasmania website. This is just a screenshot from yesterday, but you can kind of see our clinic details there, and people can search by GPs, but also pharmacies to get the medication, imaging providers where you can get ultrasound. And so this is a fantastic resource for patients, but I think we found it difficult to know when patients are kind of linked in to us, you know, how they've known about us. We didn't have that many teething issues, but we did have to think about having appropriate education in the clinic as we were slowly figuring out things like appointment times, cost to the patient, how it's booked in with the doctor. We had to not only educate our reception staff who are having to help navigate that for patients, but also the other doctors in the clinic. We sat down and did an education session about what medical termination of pregnancy involved, what blood tests and ultrasound patients might have to advance prior to coming to a prescribing doctor, things like the risks and ways to counsel, and just that we offered it. Again, accessing training opportunities for this, for us, it was really straightforward. I think, again, MS2 step is, their training is fantastic. And all of our doctors who prescribe have done that. I found it really adequate. But things like considering ultrasound training is another factor into it. Again, initial cost of setup for the actual prescribing straightforward, but I think if you're planning an ultrasound, that can get very complicated. And as I mentioned a bit earlier, we did have issues accessing external funding with the Youth Health Fund. And luckily we worked, I think it was 2 years ago now, closely with the link just to advocate for us to be able to organise the Youth Health Fund for our patients in advance. But again, that's an exception to the rule. I think you might have to just think about how that might work in your clinic if you were going to introduce this. As I said, there's the Pregnancy Choices TAS website. A few other ways that we utilised spreading the news of the services we offer is that we have posters in the clinic. We have used electronic billboards as well, and that's what the top left picture is, and that is the poster that we have up around the clinic. We've also put it into a few of the local services around New Norfolk where people might be interested in these services. We have a child and family learning centre that's been in Norfolk for a long time called Tanara, and the CHAPS service, the Child Health and Parenting Service, is run out of Tanara, so that's kind of a good opportunity for patients to be aware of it. We also have it in the local library. We've got really clear information on the website, which does make it easier if patients call and they're just kind of trying to see how long it might take to get in. It does give an opportunity for reception just to advise them where to find some basic information before needing to talk to us or to the nursing staff. We've also utilised targeted social media posts and have had a professional video done almost 2 years ago now. That's the bottom left photo, which we found was useful. It can be hard though to know how much does influence patients. I've still got patients I see for terminations that have just didn't know we offer it, have happened to see another doctor in the clinic and they're like, oh, we can do that here. So it still can be really hard to get that information to especially younger people. Also, it's difficult, I think, with sexual reproductive health services that it's often services people don't need right now. We found for our skin checks, it's maybe easier in that, you can advertise for a skin check and a lot of people would be interested in it immediately. But most people wouldn't necessarily need a termination right now. They just need to know where they're going to access it. So just trying to raise that kind of awareness in the community rather than necessarily bring more patients to us immediately has kind of been a slower strategy for us. And then what's worked well for our service, I think it's been really successful. I think it works really well for our staff and for patients. I think patients are really supported and have a lot of opportunity to continue to get support if they need from our clinic. All our staff have really been on board, especially our owners and nursing staff. I think our nurse support has been really fantastic. And I think the triage calls have really saved me a lot of hassle when, reception have dumped on me in the corridor to say, oh no, this person's called and all this stuff's happening and it's a big stress and you're in the middle of seeing people. It's just really kind of calmed everybody down and realised a lot of this isn't urgent. And if it is, we can often work around it. And I'm lucky that I can stay late and squeeze people in if it's absolutely desperate. And that's really saved a lot of stress. I think prior to having that triage call, we had a fair few patients who would call up, be in distress, and then by the time you see them, you squeeze them in quickly, you don't know what's happening. And they're too early, but like they're in extreme distress, haven't a chance to think about it. It's almost too early to give them lots of information. And lastly, just having kind of a full range of services so that, again, even if the patients don't normally come to our clinic, we can offer to kind of complete their care this time by offering, a marina insertion at the end of it or an implant on the same day of prescribing the termination, which again is easier because our nurses do that and are available for that. We'll chat about that a bit in a minute. But that really wraps up me talking about our medical terminations of pregnancy. The last few bits are the rest of the talk I've just kind of added on from the conference. So we didn't talk about this at the conference, but this might be useful information to people who want to offer more, again, sexually reproductive health services. So again, over the last almost 5 years, we have also started offering IUD insertions at Dillon Valley Medical Centre. We have our nurses do implant procedures, so insertions, replacements, removals. We now offer pessary insertion and management for pelvic organ prolapse, and we have started doing bulk build youth-targeted clinics once a month. So just for each of those 4 things, I'll go into a bit more detail. For IUD services, I think it was maybe one of the things that took a bit more logistics of planning to get equipment, but I found was actually a service that there was lots of resources available to assist in starting this up. I'll skip ahead to training. Back when I did my IUD training, it was kind of COVID times, 2021. It's been difficult in Tasmania since then, and especially around then, to get IUD training as a doctor. Especially through Family Planning Tasmania. There's not many other places who do it. There is a few, it depends, things like the bubble. I've done some training for doctors at my clinic, but again, it can be difficult to get enough patients in. So most doctors would still have their formal IUD training done at Family Planning Tasmania. Very luckily with the new federal government funding, but there are scholarships available for doctors to have training through Family Planning Tasmania as well, which hopefully will increase the uptake of GPs being able to offer IUD services. I mentioned that as well because it's such thorough training that you get an idea of what equipment you might need and experience in using that, but also things like what resources you might want to have at your clinic, how you might choose to set it up at your clinic. We have done it similar to family planning. There's now 3 inserters of IUDs at New Norfolk as well. But we have an assessment appointment for half an hour that we've had just the doctors who are inserting do. Initially, when I started doing it, occasionally patients would get a script from another doctor from Marina, and they just come expecting you just to pop it in. But we find having an assessment appointment is really important to not only go through in detail the consent, bit of a game plan for things like pain relief and what the procedure will definitely involve, but also to examine the patient and make sure there's nothing wrong with the cervix that'll be appropriate for an IUD, and that they definitely have appropriate contraception prior. And I think that's a big thing if you're setting up this service. I think deciding if you, as the doctor who's inserting, will also assess the patient is important, because there was initially lots of issues with people coming who maybe weren't appropriate. They might have come with a Marina already like in the box ready to go, but you haven't got a nurse available because they didn't really book it in properly, but the patient didn't know that. Or they might have abnormal heavy menstrual bleeding that needs investigation. So you should investigate before you decide to treat with a Marina. For the equipment, as I said, it is very straightforward, really. Like, we have a lot of equipment that we use, but it is a spectrum of what you choose to have available to you. Sexual Health Victoria has a link on their website that goes into detail and has lists of things that you might use in your clinic. That's fantastic, and what I found back in 2021, 22 when we started doing it in Norfolk. And it's great. It lists kind of things about where to get. Like, do you want a bed with footrests? Do you want to get stirrups for an examination bed that's just attached to a bed, which we are lucky to have both? And then, do you have equipment that can be sterilised, or do you have packs of disposable ones? Lots of people use either. Do you have Marinas in stock? I think it's a good idea to have a spare one. And luckily, Bayer, who's the drug company who produces Marinas and Kylenas, are fantastic at just sending to a clinic a free one of each just to have on hand. I have nightmares of just dropping a Marina and then not having a spare to put in. So I think it's really important to have a spare one as a backup. And things like, what anaesthetic do you have? Do you have gel? Do you have spray? Do you have Penthrox available? Like the green whistle? Do you have a little kit of atropine for cervical shock? Things like that. But as I said, Sexual Health Victoria have fantastic resources on their website for inserters. They also have really good resource on their website. And so that's another thought. Do you have your own patient handouts? Do you make your own autofills? Again, Sexual Health Victoria even just have the autofills on the website, and that makes it a lot easier. For fees, again, if you look around websites for clinics in Tasmania, you can see most people will charge a gap, and part of that is because of the long-standing training costs that have been around for a while, maybe no longer with the scholarships, but for a long time people have had to pay a lot for the training, and it does take a while with the nurse and the doctor. Luckily, the rebate will go up from the 1st of November this year, so it'll go from a $75 rebate to, I think, about a $200 rebate. We'd like to keep the fees the same, but hopefully that will really help patients with cost. And then obviously there's also the cost of just setting up the equipment. Like, do you choose to purchase, dilators and metal speculants to sterilise? Do you have the sterilised, like tenaculum, sponge forceps, and long scissors? Like, that's what we chose to do, but it depends if you have a steriliser machine available. There are the main things about inserting IUDs. We also do copper, and so we've chosen to keep a copper in stock in clinic so we can use it for emergency contraception as well. If it's inserted within 5 days of unprotected sex, not only is it ongoing birth control, but works as their emergency contraception. But they can take a while to order it online now, and basically no pharmacies have it in stock. Luckily in Tassie, family planning does have a lot in stock. And so, my understanding is even like in the south, the Royal will get patients just to go to family planning to buy one. But they're not on a prescription. It's technically medical equipment. And that's another thing to think about if you're going to offer IUD insertions. Do you have the copper available? Do you insert copper? Which ones do you insert? All things just to think about. Next up, we, as I mentioned earlier, we're part of the Orient trial. And so part of that was introducing nurse-led early medical abortion, but also LARCs, long-acting reversible contraception. And that helped us with our nurses get education and training to do implant procedures. We found it worked really well. We've got 2 nurses now who do implant procedures. They both did training through Sexual Health Victoria remotely, and so there's training for RNs through them, and they can do the training online, and then they'll send out those little pads where you can practice with a model implant on to get the official certificate. And then the way we organised it was that our nurses had supervised insertions with me. For our first nurse who did the training, we did a lot of them because we also trying to figure out, what's the appointment structure, what's the nurse's responsibility, what's the doctor's responsibility. But our second nurse, who trained maybe a year or 2 years after that, we found we needed, I think we had about 8 or 10 procedures in total that were supervised, but each one kind of becoming more and more independent. And that was a mix of insertions, replacements, removals. We have it set up, again, with nice autofills that our doctors are still responsible for the consent, making sure there's an appropriate contraception plan before and afterwards. Say if it's a quick start, they need to know that there'll be pregnancy test 4 weeks later. A local anaesthetic order for the nurses, just in our notes. And we have an autofill for that for doctors, so that it's kind of straightforward for even doctors who don't actually do the procedure. Really just to make sure that that contraception plan consent has happened prior and that the local is already organised. And then we book the actual procedure, and we have it set up so that the nurse has the procedure time and the doctor is just ad fit. So just on top of another appointment slot, the doctor will just swing in to be able to take over if needed, but mostly just to check it's all right, and to just be able to supervise if needed. But we found it's really straightforward. Our nurses are really fantastic at it. It's worked really well. It's freed up time for the doctor to keep seeing other patients, and our nurses have found it really rewarding and like a fun procedure for them to do. We've also chosen to charge the fee. So we still charge a gap fee for our implant-on procedures. I think we just charge the AMA rate, but when the nurse is doing it, we will just charge a short time base for when the doctor is in the room. So the patient will get like a rebate for a 3 and not the procedure code. Because the doctor hasn't done the procedure, they don't get the rebate for that. Because a nurse can't bill Medicare, but we just charge the same gap either way. So in the end, the patient is the same out of pocket, but it helps just cover the procedure and like the treatment room fees and things for the equipment that we have to use for it, things like the steri strips, the bandages, blah blah blah. Patients are really happy with that, and it definitely means they get seen sooner and it's a bit more flexible into the time of day. Often the nurse is a bit more available than our doctors. It'll be good, and I'm not sure what exactly we'll do when the rebate goes up for the procedure, just because the procedure rebate is really low at the moment, especially for insertions. So most of the cost is the gap. We might have to change that a little bit when the rebate changes, but that's from the 1st of November. And for resources, we don't use much other than the autofills in our system, but we have one for the nurse procedure and one for the doctor's consent. But some of our nurses like to use consent forms, and so RACGP has an implant-on procedure consent form, and Sexual Health Victoria has a few on their website. So it's pretty easy to find them online, but you can always make your own as well to print out and have patients sign if you'd like to. We have also started doing pessary insertions for pelvic organ prolapse. This is quite a new thing that we haven't done a lot of, but kind of came out of family planning, having funding to do it themselves. And I finished up there the middle of last year, but after I left, we started doing them in New Norfolk. We have 3 doctors who not only happy to manage pessaries, but also to fit ring pessaries. So for equipment for this, it's really straightforward. I think there's just one company in Australia who makes and the fitting kits, but also just the pessaries or distributes them, called ProFem. That's where we have, we've bought 2 fitting kits. So we have 2 Perspex boxes of sizes 0 to 10, just ring pessaries. And then there are different types of pessaries. At family planning, they've got lots of different types. But again, my understanding is lots of GPs just use the rings, but you can get fitting kits of all different types, like a ring with the knob on the end, a ring with the support shelf, and all the different types. We also have chosen to purchase in advance a couple of pessaries for patients, so that once they're fitted, if they want to go, like if they're happy with the size, they can just from us purchase the one that the size they had and take it away with them. that's really all the equipment you need. Like you normally already have an examination bed and speculum, things like that. So there's no special equipment unless you're fitting them. And to clean them, for patients' own, if they're going back in them, you can just clean it with soap and water. And we have a sterilised machine. So you have to sterilise the actual fitting pessaries between each use. You can, if you didn't have a sterilizer, use the sterilizer wipes that you use for a transvaginal probe. But again, they're much more expensive. For training, our doctors, I had lectures through training through family planning Tasmania, but there's no formal training for doctors for inserting pessaries. I would say just talking to someone who's experienced and just trying it, like it's very, very easy. And most doctors who are already doing lots of pelvic exams and, inserting IUDs and things would already have a lot of the skills needed to do a assessment of a prolapse and then just trial a pessary. Most of it is just trying a few sizes and seeing what stays in. For us, our setup with fees is we've chosen to have like normal initial appointment fee structure. So if they are eligible to bulk build, some of us, like we would bulk build that. But then for the actual fitting appointment, we no matter what charge a gap for that, and it's just a half-hour time-based fee, which ours I think is $198. But we really found, and that's with an $82 rebate at the moment, we've really found patients are happy to pay that in most situations. I think we do always offer alternatives though, because at the moment, if you had pelvic organ prolapse, and again, we normally talk about things like physio and the normal things at the same time, but if we've chosen to go ahead with the pessary, they could go through the Royal, because pessaries or through like any of the hospital systems, they give them out for free. So that would be cheaper for them, but it can easily be like a 9 to 12 month wait, potentially longer. You could go through family planning as well. And if you have a concession card, the pessary is free, is my understanding still. It definitely was last year. But again, it's easily, 6 to 12 week wait for that family planning. And so, yeah, some patients are happy to pay for it and have it locally, and other people would prefer to travel and have it done for free. We also take a deposit of $50 at the fitting appointment when they go away with the fitting pessary inside them to see how it goes for 2 weeks. And then when they come back in 2 weeks and we just touch base on how it's gone, if they choose to then just take pessary of that size for themselves, then they just will keep that deposit, and that pays, the $50 pays for the pessary. If they choose not to keep it, then we'll just take back the fitting pessary and they get that deposit back. Part of that cost is just in case someone took one of the fitting ones, you do buy a full fitting set, which is I think $350. And so if they took one of them, you have to consider about having to buy a whole new set again to replace it. So it just kind of covers that fee in case they didn't come back with it as well. You can from ProFem get fitting ones of just the common sizes 3, 4, 5. But if someone was to run away with like a size 7 and now you've lost that in the fitting kit, you might need to buy a full another one again. So that's how we've decided to organise it. And for resources, we don't use anything special for this either. We do have autofills that the three of us obviously insert kind of done together, just to again prompt for things like just counselling things to mention. But we don't have any paper handouts for patients. If we do, often I just use the Royal Women's Hospital handouts on pelvic physio for patients. But no, it's been a really straightforward and really rewarding thing to offer to patients. But we have really hit and miss uptake. Do a couple in a row and you have a while of nothing. But it's been not only useful for having it for postmenopausal women, but I think again more and more recognizing that postpartum women need it. So actually most of the ones I've done are in women who are in their 30s, which is worked really well. And again, I'm really happy to have that service. The other place where I forget to get these is that the private pelvic physios also do insert pessaries. And so that's another way if you want to get your foot in the door and try it a little bit. But if you have any problem solving issues, you could just send to a physio and just find out what they do, kind of learn from experience that way as to maybe some of the other options you might have for problem solving inserting pessaries. And then lastly, our youth targeted clinics. This has been a new initiative we've had this year. New Norfolk is a really disadvantaged community, as I've already mentioned. Lots of difficulties in the local high schools, and it's the state government has given extra funding to the link to be more involved in the community. Separate to that, we were just already in talks with the link regarding our youth access workers for terminations. And so we spoke about trying to as well be more engaged with that population. Most people, because again, we're mostly private billing clinic, even if they would be eligible for reduced fees for say things like chronic disease care plans, often those children, those like adolescents, kids, children, young people, because they're not currently patients in the clinic or because their parents don't want to pay for them to come either, often they're just, again, not engaged with our service. So we decided to do once a month at the moment clinics. I think it's the first or second Monday of the month, just an afternoon clinic. And we have, I think it's 6 doctors rotating through. So it's for each doctor, it's just twice a year, a bulk billed clinic that's just kind of back to back, essentially like a triage appointment where you might have the opportunity to talk about STI screening, contraception, pregnancy things, mental health. And then if we needed to have a longer consult or go through something in more detail, then we can offer that. And it's easy for us to organise, say something like the Youth Health Fund to come back from a mental health care plan and help them kind of get their foot in the door to organise that themselves. We have had to do a lot of like advertising to the schools though. So we've been lucky, we've had little booklets we've made up and organised, and the link has given out for us. But we have been organising, trying to talk more and have our doctors go into the high schools just to talk about it. And as I mentioned, for us, we don't get any extra funding for this. It's just something we've decided to do to accept the Medicare rebate, even though it is a lot less than our like normal fees and service would cost. One of the reasons we do have it kind of back to back as well, so that normally our doctors have kind of a break multiple times in the session. But the aim is, again, more to be kind of short, sharp appointments to kind of problem solve for people and get them back if they need to. But it's an ever-evolving thing. So far, it's not been really high uptake, but we're working more closely with the schools to try and have people more engaged. There's just a few references for the stats and the pictures. And then, just lastly, this is the last slide on the AusCaps network. So if you're interested, I'd recommend, definitely signing up. There's heaps of resources available. I don't think I mentioned, but a lot of the resources as well, like handouts and things, are also on this website, and a lot of training opportunities are listed on the website. Excellent. Thank you.
Thank you, Gemma. I learned a lot from that, and I've even read your slides before, so thank you so much. We've got a little bit of time for some questions. I'm going to start while we give people some time to put some questions in the chat. My major question was, clearly your practice has made a huge investment in improving access to reproductive health services in the Derwent Valley. Investment in ultrasound equipment, for example, investing in training nurses, bringing on more female GPs, and all the training that goes with that as well. My question is, have you been able to sort of estimate or measure the impact that's had on the patients and the community that you work in?
That's a really good question. And actually, when I wrote this talk for the actual conference, I've been thinking about, what patient feedback we've had. I think it is all anecdotal. I definitely feel like, especially with our termination service, patients have been really happy and appreciative. I think it's been really successful how we run it. Often patients who've come for IUDs have been really impressed, and actually often are still surprised despite our advertising that we offer it. And we get a lot of friends telling friends. And so you have runs of doing a lot of it because everyone in the community talks. But we haven't actually done any formal feedback from patients. But I say anecdotally, I've noticed a big difference since I've been there, especially as when I started in 2021. We didn't have any of these services. I think there's also a lot of non-tangible benefits. I think there's a lot of satisfaction for the staff as well. And definitely me and the other doctors who provide this, I think, we really enjoy it anyway. But also that's just rewarding. And I think that's another huge benefit. And same for our nursing staff. And I think that also helps encourage doctors to stay in the area and to just, be doing what they want to be doing.
So many benefits from that investment.
Yeah.
I've got a question in the chat for you from Lucy. Could you tell us a bit more about the how important the support of the rest of the team was for getting started to doing this work? And there's a second part of the question as well. And do you have any thoughts or advice for GPs who might be in practices that are unsure about starting to offer MTOPs and LARCs?
Yeah, I think they're great questions. And I think probably a good insight working in family planning, I worked with a few other doctors who also worked in normal general practice who were also not offering it in their normal general practice or thinking of it. I think knowing how other doctors found other clinics, I already knew it was a huge, huge benefit having the rest of the team be on board. But I think, in so many ways, it made it so much easier. Just having, a practice manager and reception staff who are on board with facilitating with what you're going to bill, how they're booking the appointments is really invaluable and can be really difficult if you're working in a clinic yourself and just being the only person who wants to prescribe. It can be difficult to navigate those logistics, especially because it's such a specific thing, and that can make it really confusing for patients if reception's booking them in the wrong time or the wrong appointment length, as well as it's been just indescribable how lucky we are to have our nursing staff as well. And I think again that double benefit, our nursing staff are really interested in this kind of area of medicine as well, so I think it provides them that satisfaction in their job. But also I think that kind of team-based approach is not always possible in general practice, and we're just lucky that again we're such a tight-knit clinic that works really well and has passionate people who are on the same page. There is a lot of clinics that don't have that, and again I think it can be hard to make them have that if your nursing staff aren't interested.
Yeah.
And so that can be challenging. And if people do want our autofills for what we use, feel free to contact our clinic. That's happy to give that out. It can make it a lot easier. A lot of the challenges sometimes we're just figuring out those things, what exactly are nurses responsible for and what they can be comfortable doing. There was a lot of teething just for us to figure those things out.
Yep.
And then for GPs who are interested in offering MTOPs and IUDs, as I said, I think there's so many resources out there now that do make it a lot easier. Hearing all this can sound like there's a lot to think about, but you can just kind of dip your toes in the water and start prescribing. And I'd say most of my colleagues who I've worked with at family planning who do it elsewhere, that's more how they do it. It's very ad hoc. People come in and they're like, oh, okay, most of them have access to ultrasound, so it's just an incidental appointment. And then they realize, oh, you need a medical determination. Fine, we'll just do that initial consult and organise an ultrasound. And then as the doctor, you can easily decide, okay, I'm going to get back and do a double appointment. Do I charge you more? It's just very as you go. And sometimes just doing more helps get that experience and helps you think about what you might want to do. I think some of the ways we do it helps kind of navigate maybe some of the barriers that make it more difficult. And so again, if you're doing more and more, it might help set you up to know it's been really difficult because people aren't booked long enough appointment and they run late forever. I need to fix it this way. Or they came way too early. Maybe I needed to tell the reception to help book them in more close to 6 weeks gestation. Those things you can just really figure out as you go. And it was similar with IUDs. IUDs, you do need more equipment to be able to manage, complications from it, side effects, just having a bit of awareness if you were starting that to know what you'd do in XYZ situation if something did go wrong. But that is more fed to you through things like Sexual Health Victoria and just having the training done yourself. So I think that's easier because it's a bit more handheld, and that's a bit more of a standard process that most people would go through. And it's much more common, I think, for GPs, the way that people would insert IUDs and have their appointment structure is pretty similar across GP practices. Okay. So you could just talk to peers as well, or again, come out and talk to us or email me or on Facebook. I'm happy to talk to anybody about it. Because again, initially, I think it can seem like there's lots to organise, but there's so much online. There's checklists. Even just yourself after the training, if you were to think about what you might need, is actually really straightforward once you get into it to think about that. I guess the cost of the investment for the clinic might be the challenge. And back in 2020, when I started in general practice, there was a doctor there who also was family planning who started doing Mirena insertions. It took her 12 months from starting to talk to them about it to being able to be prepared to insert her first one 12 months later, mostly from the equipment and protocols that the clinic wanted. And so I guess also having the back of your mind that, sometimes there is logistics that maybe need to be organised. But again, I think it's not a difficult challenge to overcome. And I think, again, it's rewarding part of it to be able to figure out how you're going to offer that service. Yeah.
Well, thank you so much to you, Gemma, and also to Derwent Valley for leading the way and sharing your experiences in improving access to reproductive health services in regional areas. It's been really valuable. I'm just going to slip in one question before we finish, which is, what's next for you guys? Have you got more plans?
Good question. Yeah, I think, where's the line? I think I think we're really happy with these things. I think these were things that when I started the clinic, and it's one of the other doctors, Zoe Dodge, really wanted to be offering. And I think we're really lucky at the clinic just that it's gone so well and it's already now established. There's always more we could be doing, we could be doing more with youth targeted things in the area, definitely. We could be doing more different types of pessaries, and I think we could be doing more pessaries if we advertised it, but we also almost didn't want to do too much of that at once. And so we've actually avoided advertising that too much, just because, again, it's just so busy all the time anyway, like just busy doing normal general practice.
Yes, I can imagine.
Yes, yeah.
Well, thank you. And thanks for everyone that's attended today. As we said earlier, we'll send out a link to this presentation and it'll also be available on our website, hopefully next week. Gemma's offered for people to contact her if you have any other questions. But thank you again for joining us, and I hope this information and presentation has been really valuable for everyone. Thank you, Gemma. Thanks, everybody.